dear physicians. Today is the 88th session of ECG lecture organized by study group, ECG Basic Beyond. And topic of today's lecture session is what antiarrhythmic drugs to choose and why. And speaker of today's lecture is Dr. Azizul Hoque, eminent physician and consultant cardiologist, Division of Cardiology, Emory University School of Medicine. As usual, before the start of the lecture session, I want to request Professor Abdul Chowdhury sir to say few words regarding Dr. Azizul Hoque sir. Following that, we will start the session. Wadud Chowdhury sir.
Yes, Assalamu alaikum. Today we are going to talk about what antiarrhythmic drugs to choose and why. This is a very interesting one because we use some of the antiarrhythmic drugs quite frequently, and some of them we're quite afraid of using because of our lack of understanding where it will be of much use. I think today's lecture will help us to understand which drug to use where, why, and when. And it will be also useful to understand when we are going to create more problem with the use of a drug rather than helping the patient. And that's the most important thing, I think, that will be of this lecture. And what about Professor Azizul Hoque? Aziz Bhai, our favorite Aziz Bhai, I do not think those who are attending this lecture for last 2 or 3 years need to have an introduction about him. He's someone who can easily relate to regarding an intellectual problem. And he will think about it, he will give a very thoughtful answer, and he will also help you, guide you, and rather, I would say, how to construct a decision from a quagmire of problems. Aziz Bhai, the field is yours. We are eagerly waiting for your lecture.
Thank you very much, ECG study group. This is a nice forum, definitely. And this lecture actually mainly designed for our cardiology fellows, and we're getting in training for cardiology. I hope they will join more because it's a very interesting topic. Even we are attending sometimes face difficulties about what antiarrhythmic drug to choose and what situation. And a lot of information are evolving in that area, so we have to keep up with the literature data, and definitely guidelines always behind those data. So we have to be careful because those are very important medications, and they come with some baggage with side effects and long-term side effects actually, and with some medications. So without further delay, let's start. So basically, we'll try to understand some mechanism of arrhythmias and choose the best therapy depending on the mechanism of arrhythmia and with the current data and guidelines that we have. And definitely, we'll always be careful. That's our learning objective when you choose some antiarrhythmic therapy, what are the pro-arrhythmic effect of the drug, and with all our potential antiarrhythmic drug therapy. So I have nothing to disclose. Let's start with cases, because I'd like to talk with my real cases sometimes. And some of the materials definitely I borrowed from ACC, but most of them are from our own own patient population. This one of my patient is 70 years old with history of cholesterol problem. That's the only medical problem he has. And by the way, he's a physician also. So he comes with recurrent chest palpitation. And he reports that when he has this palpitation, he feels dizzy and discomfort, and also some chest tightness with that during those episodes. Normally, he doesn't have problem, but definitely when he has the symptoms, he feels some chest tightness, pressure, and dizziness. Okay, so he's physically active otherwise, and his only medication is cholesterol, like atorvastatin. He takes 20 milligram, blood pressure 110/70, pulse 76. Oral vital signs are okay. And we did the EKG in the office. That's your first ECG. I think it's probably in March or February that time. We see some extra beat of the heart, okay, frequent extra beat. is anybody could comment on our trainee site? Anybody can pick up on the EKG and comment on that? Anybody on the attendees that we have like 24 joined already, our doctors, medical trainees. Anybody want to comment on that?
Just raise your hand
Yeah.
in the Zoom so that we can understand.
Anybody, just don't be afraid because we want to make it interactive. Okay.
দেখতে পাচ্ছ ওটা বললেই হয় যে কোন জায়গাটায় প্রবলেম মনে হচ্ছে তোমাদের।
হ্যাঁ। Okay, একজন হাত তুলেছেন, ডক্টর আশরাফুল। Let him give the option.
Amrul, please make Dr. Ashraful visible.
I'm really asking the audience who are mostly from Bangladesh that if you need to express yourself, use Bangla if you think that you are comfortable with that.
Yes, that is fine.
Sir, this might be a case of
Okay.
Hello, assalamu alaikum, sir.
Alaikum salam.
Sir, this is a 12-lead ECG showing heart rate. About 80 beats per minute. There is a sinus, and there is also presence of a white complex that is ventricular PVC, ventricular ectopic beat from B1 to B6, B1 to B6, and also in ABL and ABF, followed by a pause. And there is presence of Q wave in lead 3 and ABF.
So you are seeing PVCs. Is there are they single or couplets or anything else about them you want to talk?
So they are trigeminy pattern.
Not trigeminy. There are couplets and singlets.
Yes, sir.
Okay.
So are they from the same focus?
No, sir. They are not the same focus. They're not from the same focus.
Aditya will be making comment about that.
Let's see. I think at least we have some idea. Definitely, we know the major problem of these patients really having a lot of PVCs, right? And look at that, and the rhythm strip, the single rhythm strip, is probably from the same focus. You know, look at the QRS morphology. And if you look at that, it's probably coming from the same focus. It may come a little bit early, that's why you see a slight change in complex, but overall, this one looks like similar, okay? And also, look at that, sometimes they are in couplets also. The দুইটা একসঙ্গে হয়েছে, তাই না? যখন আমরা দেখবো তখন এই সিম্পটমগুলো কিন্তু পেশেন্টকে বদারসাম করছে, হ্যাঁ? He is feeling dizzy, maybe it's happening more. Symptomatic. That's the main purpose. Okay, all antiarrhythmic drug, when you choose, your main purpose to make sure the patient reduce the symptoms. That's our main purpose of that. Okay, so এখন দেখছি আরো it's important দেখছি যে আমরা দেখতে পাচ্ছি যে V1 লিডে দেখতে পাচ্ছি যে এটা রাইট বান্ডেল মরফোলজি, তাই না? রাইট বান্ডেল মরফোলজি আর কি, হ্যাঁ, এবং ফোকাসটা প্র্যাকটিক্যালি সেম, একটু স্লাইড ভেরিয়েশন, বাট ইটস নট লাইক পলিমরফিক. It's definitely single place is coming, but এখন প্রশ্ন হচ্ছে কি এটা কোথা থেকে আসছে, তারপরে তখন আমরা দেখবো কি অ্যাক্সিসটা কোথায়, এই পিভিসি উপর থেকে আসছে নাকি নিচের থেকে যাচ্ছে। হ্যাঁ, যদি উপর থেকে আসে তাহলে আমরা লিড থ্রু 2-3 AVF এ পজিটিভ ডিফ্লেকশন দেখবো, কারণ এটা নিচের দিকে যাচ্ছে, ইনফিরিয়র লিডস গুলোতে পজিটিভ ডিফ্লেকশন, not apex, from the base somewhere, okay, close to the base, কারণ উপরের থেকে নিচে আসবে, এপেক্স হলো নিচে, তাই না? এপেক্স নিচে, এদিক থেকে আসলে আমার ইনফিরিয়র লিড 2-3 AVF রিফ্লেক্ট দ্যাট ওয়ে, বুঝছো, দিস পার্ট। সো এদিক থেকে আসলে তখন এই লিড গুলোতে পজিটিভ ডিফ্লেকশন হবে, হ্যাঁ, যেটা আমরা বলি ইনফিরিয়র পজিটিভ অ্যাক্সেস আর কি, হ্যাঁ। তো এখানে দেখেন আমরা যদি আমাদের রিদম স্ট্রিপ নাই, কিন্তু তবুও আমরা একটু খেয়াল করলে দেখতে পাবো, লুক এট দ্যাট এভিএফ আছে আমাদের কাছে দুইটা পজিটিভ, হ্যাঁ, লিড 2 আছে দুইটা পজিটিভ, হ্যাঁ। So আমাদের so it looks like that it's in the positive direction, like inferior axis, তাই না? অ্যাক্সিসটা উপর থেকে নিচে যাচ্ছে। সো এবং তখন আমরা বুঝতে পারবো যে পিভিসিটা আসতেছে উপরের কোথাও থেকে, বেসের থেকে সামহার, হ্যাঁ। এখন হচ্ছে এটা রাইট আরভিওটি অর এলভিওটি, উই ডোন্ট নো, অর অ্যাডজাস্টেন্ট টু দ্যাট এরিয়া, তাই না? কিন্তু উপরের থেকে। এখন যদি আমরা ক্রাইটেরিয়া দেখি যে এইটা যদি আমাদের পিওর লেফট বান্ডেল মরফোলজি হতো V1 এ এইখানে, তাহলে আমরা ভেরি মাচ শিওর যে এটা রাইট আরভিওটি থেকে আসছে, হ্যাঁ, আরভি অস্ট। কিন্তু এখানে আমরা লেফট বান্ডেল দেখতে পাচ্ছি, তাই না? এবং ট্রানজিশন ইজ আর্লি, তো লাইকলি ইট ইজ প্রবাবলি এলভিওটি এরিয়া it is coming. So that's a quick way to understand. You don't have to, but there's a quick way to understand, particularly for the cardiology fellows. Yeah, they need to know that. Okay. So there's an article I'd like to share with you. It's published in 2019. Very nice article. You know, it gives you pretty much a map where this PVCs may come from. Okay. So you can take a snapshot of that. Of these articles published in circulation, but look at that. If you look at that, our V1 lead little bit positive, like here, তারপরে আপনার 3 AVF positive, মানে a positive inferior axis, V1 lead. So if you look at the criteria of that the PVCs we have, it looks like in the LVOT area, and most likely we call aortomitral continuation area somewhere here in this map. Okay. Somewhere here. You don't have to know that, but at least some idea that it's probably outflow tract VT, and likely it's LVOT tract VT, okay? And that is like aortic valve and mitral valve is somewhere here in this continuity area, okay? So let's now, how you're going to deal with this patient, like, and then you have to do some workup, right? What's the burden of the PVC is this patient, which patient is symptomatic. So the first thing you do, definitely do a monitor how much, in 24 hours, how much burden of PVC is patients having. এবং এই পিভিসি গুলা যদি ফ্রিকোয়েন্ট পিভিসি হচ্ছে তার লেফট ভেন্ট্রিকুলার ফাংশনকে কোনো ডিটেরিওরেট করেছে কিনা। So echo is important, and also Holter monitor is important, okay? And we see that echo is ejection fraction like 45-50%, a little bit down, not like significantly down, but mildly down. Okay, no other major valvular abnormalities and normal cardiac chamber sizes. Okay, and PVC burden আমরা দেখতে পাচ্ছি তার about 6.8%. Okay, we know that high PVC burden more than 10-20%, they normally get cardiomyopathy, we call PVC induced cardiomyopathy. And also আমরা দেখতে পাচ্ছি যে তাদের non-sustained ventricular tachycardia হচ্ছে not too long but 4 to 6 weeks, this particular patient. তার মানে তার symptomatic হওয়ার কারণ রয়েছে, তাই না? The PVC burden is not low, it's in the mid portion, and also he's having some short-run non-sustained VT. Okay, আচ্ছা, এখন এই ধরনের পেশেন্ট সে আবার বলছে তার চেস্ট টাইটনেস হচ্ছে যখন এই ধরনের সিমটমস হয়, এবং সে 70 years old, হ্যাঁ, তার কোলেস্ট্রলের প্রবলেম আছে, কিন্তু অন্য কোনো ডায়াবেটিস নেই। তখন he underwent a heart catheterization. I'm giving some information, and there's no significant obstructive disease, only luminal irregularities, about 20% in mid RCA, but LAD and other areas, not much disease. So we call it like minimal, like luminal irregularities or non-obstructive coronary artery disease, but he does have some minimal disease, okay? So definitely, I'm a clinical cardiologist. I sent the patient to EP, and since he has been symptomatic, think we can do some more like permanent, treatment for them, and with his potential catheter ablation is good for him. But he's a physician, he's still not considering it, EP ablation, okay? So, and we tried already to increase the dose of metoprolol, but his blood pressure is borderline, he's not tolerating it. When you go to 25 he was on 25 milligram, he go to 50, he feels dizzy a little bit. That's not due to the arrhythmia or bradycardia, is dizzy because the blood pressure runs like 90 in that range. 95, he feels dizzy with that. He doesn't have hypertension to begin with, তাই না? আচ্ছা, এখন তাহলে এখানে কিন্তু পোল করা যায় এটা।
Yes, sir, poll can be given.
Yeah, a poll to call. What's the next appropriate step? Okay. Yeah, let's do that. Let's everybody participate, and we'll discuss more thoroughly.
30 seconds. Make it for 15 seconds. Okay.
এই কোশ্চেনটা খুব ইম্পর্টেন্ট। এই জায়গাতেই সবাই প্রবলেম পড়ে যায় যে রোগীর তো সিমটম আছে, আমাকে রিলিফ করতে হবে, হুইচ মেডিসিন আই এম গোয়িং টু ইউজ।
Rafique sir has joined the session. Rafique sir,
Okay, that's great.
Hello, assalamu alaikum. Bye.
Hey, Rafique, this is your area. I need your help and discussion. Okay, thank you.
স্যার
আমি একটু বাইরে তো কথা বলা বস্টনে আসছি, but I'm listening.
Okay. All right, let's do the poll results. So we see wide variation, okay? A, B, C is almost similar, 20, but a lot of people chose D. Okay, let's discuss that. Before we go further, very interesting thoughts, but I'll talk about that. That's the reason the discussion is, because I like to make it interactive. Anybody can participate in the discussion. আমরা যখন আমি অ্যানসারগুলোতে আসছি পরে, কিন্তু প্রথমে দেখি যে এই যে আমার পেশেন্টটার হোয়াটস দ্য মেকানিজম অফ দ্যাট অ্যারিথমিয়া, হ্যাঁ, এই যে এলবিওটি ভিটি হচ্ছে অথবা পিভিসিস হচ্ছে, হ্যাঁ, উই নো দ্যাট ডক্টর রফিক স্যার আলাপ করেছেন, ডক্টর চৌধুরী আহসান অলসো টাচ দ্যাট এরিয়া অলসো নট লং গো। সো উইথ দিস যারা অ্যান্সার করছেন, আরেকটা পোল হয়ে যাক এখানে, হ্যাঁ, কোন মেকানিজম এটা হতে পারে, একটা পোল দেন তো একটা আবার।
কামরুল, এটা এই স্লাইডটার উপর একটা পোল দেন। Okay.
Very
Stop
quick
for
poll.
15 seconds. Stop.
Triggered activity.
Okay, let's see the poll. Okay, so most people chose abnormal automaticity. Okay, now we have something to discuss here. Okay. All right. So what is abnormal automaticity? এটা হলো কি যেটা আমাদের excitation করা যায়. Here I'm showing the slide of the sinus node or the AV node, but it could be also extrapolated in the myocardial cells. এটা হলো কি abnormal automaticity, আপনার যখন একটা অ্যাকশন পোটেনশিয়াল শেষ হয়, তারপরে একটা যে ফেজ 4 এ যায়, রেস্টিং পোটেনশিয়ালে যায়, কিন্তু ওই রেস্টিং পোটেনশিয়ালটা যদি একটু দ্রুত বেড়ে যায় ইন্ট্রাসেলুলারলি কোনো কারণে, তখন হয় কি অটোমেটিকলি আবার একটা অ্যাকশন পোটেনশিয়াল শুরু হয়ে যায়, হ্যাঁ, তার মানে ইনক্রিজড অটোমেটিসিটি বলি আর কি, হ্যাঁ। তো এইটা রেস্টিং পোটেনশিয়ালটা বাড়ার জন্য হয়। এটা কি কারণে হয়? মেজর কারণ, যদি সিম্প্যাথেটিক টোন বাড়ে, যদি ইসকেমিয়া হয়, ইলেকট্রোলাইট ইমব্যালেন্স হয়, দে ক্যান ডু দ্যাট। ওকে, সো অলরাইট, আরেকটা যে সেকেন্ড মেকানিজমটা হলো রিএন্ট্রি মেকানিজম, হ্যাঁ। The reentry mechanism, you know that you have to have two pathways, one একটা slow pathway and another হলো a fast pathway, হ্যাঁ। কোন একটা ইম্পালস যখন আসে, definitely it will go through the fast pathway quickly. It also can go to the slow pathway, but it goes slow. Okay, by the time it goes slow, the impulse goes to the fast pathway, it goes quickly to the ventricle and can go backwards. But then they face the electrical impulse that's coming to the slow pathway, and they face each other, they neutralize that. So we don't see that. And the slow pathway conduction, effective of the slow pathway conduction, we don't see that, but it gets neutralized. Okay, we mainly see when you have two pathway, fast and slow, mainly conduction goes to the fast pathway and then goes backwards and neutralizes there. So we don't see it. কিন্তু কোনো কারণে যদি একটা এক্সট্রা বিট হচ্ছে, একটা কোনো কারণে একটা লাইক পিভিসি, পিএসসি যদি হয়, তখন হয় কি এইখানে যদি রিফ্র্যাক্টরি পিরিয়ডটা ক্রিয়েট করা হয়, যে এখান থেকে কোনো ইম্পালস যাচ্ছে না, অ্যাবসলিউট রিফ্র্যাক্টরি পিরিয়ড, দ্যাট পার্টিকুলার মোমেন্ট, হ্যাঁ, তখন হয় কি এখানে সে ফাস্ট পাথওয়েটা বন্ধ হয়ে যাচ্ছে, যেতে পারছে না। কিন্তু ইম্পালসটা কিন্তু স্লো পাথওয়ে দিয়ে যাচ্ছে, আস্তে আস্তে যাচ্ছে, গিয়ে ভেন্ট্রিকলকে এক্সাইটেশন করছে, এবং হি ক্যান কাম ব্যাক টু দ্য ফাস্ট পাথওয়ে, এবং তখন বাই দিস টাইম that refractory period is over, cell got, that excitation become more available, the excitation, so it can come back to the backwards to the fast pathway. তখন হয় কি এই স্লো pathway দিয়ে যেটা যাচ্ছে, এটা যাচ্ছে, এক্সাইটেশন হচ্ছে, কিন্তু it can come back to the fast pathway and create a re-entry circuit. এবং যদি এটা এভি নোডে হয়, তখন আমরা দেখি retrograde P wave দিচ্ছে, সেটা আমার atrial excitation করে আর কি। That's the mechanism of retrograde P wave in re-entry. But re-entry can happen in myocardial tissue also, if you have a scar tissue, any heart attack, MI, অথবা যদি আপনার hypertrophic cardiomyopathy, ওখান থেকে যেখানে আপনার অনেক থিকেন হার্ট মাসল আছে, সেখানে অনেক সময় আমি যখন দেখি যে ওখানে fibrous tissue গ্রো করে ওভার টাইম, the myocardial tissue degenerate হয়ে, এবং যেটা আপনার যদি আমরা MRI করি, যে gadolinium enhanced MRI, you can see some patches of the scar tissue that can form a nidus for re-entry mechanism, because they might have one area could be fast, one area could be slow. But same thing can happen in even dilated cardiomyopathy. There could be some patch of tissue, scar tissue, and that can create a circuit of re-entry. So that's a re-entry mechanism. তারপরে আসতেছে যে third mechanism that I'd like to share is called triggered activity. Okay, triggered activity to holo ki, if you look at the action potential, normally triggered activity amra dekhi either phase 2 or phase 3 te, অথবা phase 4A. And it is a nice name, it's called after depolarization. So if you remember that after depolarization, this is the depolarization phase, right? So it happens after the depolarization, in the repolarization time, okay? So if it happens in between stage 2 to 3, we call early after depolarization, early after, or EAD, early after depolarization. If it happens in the delayed phase, like phase 4, we call DAD, or delayed after depolarization, okay? So এখন এটা কারণটা কি after depolarization যে triggered activity হচ্ছে, এটা হচ্ছে কি at certain situation, if it's a certain condition that creates in the cell, that creates oscillation of the membrane potential. We call oscillation. You see the tiny oscillation of the membrane potential, tiny oscillation of the membrane potential, and also tiny oscillation of the membrane potential. Okay. Yes, QT prolongation can cause that. Hypokalemic electrolyte imbalance cause that. And the slower heart rate, we see that they're more vulnerable in that stage. Okay, that's why you see problem with the slower heart rate with class C antiarrhythmic medication like sotalol, amiodarone, this group of antiarrhythmic medication. They have more problem. They're slow heart rate. They have more potential to cause QT prolongated induced arrhythmia. Are delayed after depolarization, DAD যেখানে আছে, সেটা mainly হয়, if you look at the final mechanism, is extracellular excess of intracellular calcium load. Okay, intracellular calcium load. It can be triggered most commonly, catecholamine, like sympathetic activity if you run, or sometimes you can see some PVCs. If you put a patient on the treadmill, তখন দেখবেন কি হঠাৎ করে treadmill যখন at the very high level of exercise, they're having some PVCs. If they're frequent PVCs, they're probably happening that one catecholamine induced or sympathetic drive is causing this intracellular calcium load, that causes this oscillation of the membrane that can trigger an extra beat, okay, trigger an action potential. So that's the mechanism of DAD, delayed after depolarization. In this patient, we know that this outflow tract PVC is going on and non-sustained VT is going on. This most likely related with this triggered mechanism. It is related to triggered mechanism. So the answer that you chose, like automaticity, probably not the right answer. Definitely the answer is the DAD, delayed after depolarization, and the mechanism is there, excess intracellular calcium load. And what's precipitating that, that's different. That could be increased sympathetic tone, catecholamine, ischemia, digoxin toxicity. So, and that risk increases at faster heart rate.
So, Azizbhai.
Yes.
So, I don't know, just to simplify, and I always think about this, is যেমন এক গানের মাঝখানে আরেক গান শুরু হলো অটোমেটিসিটি, এক গানের মাঝখানে chaos তৈরি হলো, তাহলে হচ্ছে যে ট্রিগার্ড, আর একই গান ভাঙা প্লেয়ারের মতো বাজতেছে, ওটা হচ্ছে রি-এন্ট্রি। যেটা to choose the drug, we need to have to understand that which phase of the depolarization is happening, 0, 1 or 3, for example, in terms of automaticity or triggered. However, that is not the only thing we need to look at. We also need to look at the drug that we are choosing. Where is the tissue? the same thing, automaticity, for example, atrial tach or ventricular PVC, we have to use lidocaine for ventricular, whereas we'll have to use atrial tissue, which can be, controlling these many ways, such as procainamide, or, you can use the flecainide. But for ventricular, the drug has to be something that works on the ventricle. So automaticity, and there's a considerable overlap. For example, ischemia can give automaticity, but also can definitely give the triggered activity as well. And in your case, it is very interesting because I don't know what is Rafique Bhai's. I'm not sure this is triggered. It can be automaticity is the prime trigger here. And one of the thing, and with the EF45, maybe infiltrative cardiomyopathy, we need to exclude. I don't know.
Yeah,
he's a physician, whether he had that or not. But drug-wise, metoprolol is a good choice. But the question is, what we are trying to achieve is suppressing the PVC. We may not see much benefit. And sometimes if it's a bothersome, then sedation has a role. So that part is little slippery slope, that unless we know the underlying pathophysiologic mechanism.
Okay.
Rohit sir.
Rohit sir. Shunda Bacho.
Yes, sir. What's your thought on this scenario?
Okay. So interesting, because I think the poll, the answer was fantastic. Majority said automaticity, and the small percentage said triggered activity. When we do ablation of PVCs, we find that as soon as you start the ablation, there is some increase in PVC that supports trigger automaticity. Second, it is very difficult to prove triggered activity in clinical scenario. The only way we can do it if there is an offending drug like digital is, and we find a consistent relationship between the previous QRS and the next premature beat, we can make this supposition. So I think the excellent answer at automaticity, majority will be automaticity, second will be triggered activity. Re-entry for PVC itself, it is very difficult to prove that a single beat is due to re-entry. Unless there is a tachycardia, then we can definitely prove during EP study. Question is, what Hafiz said, management. You see, the problem when we manage patients, we have to look at few things: symptom, mortality. To me, those are the two key issues, and on them, mortality is the major issue. So, also the other thing that you see, if somebody comes with PVC, and I, as a physician, say, oh, you need an ablation. And that can create a significant degree of anxiety and unsatisfaction. So we have to carefully evaluate these patients, whether they really are candidate for ablation. Is the modality proven to be beneficial, decreasing mortality? And all of us should be carefully looking at those. The other part is cardiomyopathy and PVC. Which came first, chicken or the egg? It is possible that somebody developed cardiomyopathy and started having PVC, or maybe the other way around. Again, that is something very difficult to prove. We try to carefully treat this patient and try to prove and disprove that. Thank you.
That's interesting. Did you pull this slide? Not yet, right? Can you pull the slide quickly? Then we'll discuss. We already talked about the mechanisms. So you know the history right now, what we came from. So with your idea, what's the best drug could be that, and patient doesn't want any ablation yet, he's a physician himself. So we had some story that we already gave earlier.
Okay, stop the poll now.
All right, we have some good distribution. All right, let's talk about that. Okay, so first thing is that, you know, the question right now, amiodarone is a serious drug. We don't want to commit the patient on amiodarone unless the other drugs fail. And definitely amiodarone is more beneficial if the patient has LVEF is really low, mostly below 40%. The question about whether we want to start sotalol right away, okay? So that's also another concern we have. The patient has some degree of LV dysfunction, whether they want to, decide whether that would be good for not, and that's most likely sotalol is good drug for a flutter fibrillation, but not much with like if it is a triggered activity, how much is going to help that drug. Verapamil is a drug that definitely sometimes it helps. It's like idiopathic fascicular VT. Otherwise, it doesn't have much role. It's non-sustained VT, that drug, okay? Increased metoprolol, definitely, if the patient could tolerate. We talked about that. That's the first line therapy you always start. He could tolerate, but looks like he feels dizzy. He is currently on 25 milligram. He feels dizzy we already tried that when you increased 50, he feels dizzy, his pressure runs borderline low. So that's making him a little bit more symptomatic. So in that choice, probably flecainide could be an option. Let's discuss that. How the flecainide works, okay? Definitely is a class 1C drug, and we know that class 1 group that mainly binds to the sodium channel. And class 1C is more potent in binding the sodium inward channel in rate and voltage dependent manner. What they do, they create the slope, the zero phase, they put it on the right side and also decrease the amplitude of the potential. And also the overall action potential is slightly delayed, okay? So mainly when you give a flecainide or class 1C drug, you expect that the HV interval might increase and QRS duration might increase. About 10% you can allow. By increasing, since they're increasing the duration of the action potential and effective refractory period. But the problem that you need to be very careful when you start this medication, because you need to have an ECG done within 3 to 5 days, maybe at least within a week, to see how much effect it has on the QRS duration. Remember that class 3 agents, they affect on the QT mainly after the ST segment, not much on the QRS, okay? Class 1C agent, they prolong the whole QT by increasing the main QRS duration. So you have to measure the QRS duration itself, because if it goes like above 15%, then you're worried that whether you need to stop the medication or choose different antiarrhythmic medication, because then side effects profile is higher, okay? And also the, flecainide has another effect, despite that working on the phase 0 sodium inward channel, it also directly affects, it blocks the ryanodine 2 receptor channels. And that way it can target the molecular defect of a certain entity that can cause like calcium-induced tachycardia or DAD, delayed after repolarization in that area, some sort of tachycardia. So it has some dual effect on that. So we did that, and we did repeat ECG I think he came in 5 days. And I'm going to put it there, the previous EKG of this patient. That's the first EKG I showed you. This QRS is not that wide, it's a little bit narrow complex, okay? And we see the duration, and I'm giving you help that it was 138 millisecond, okay? It was about 110-ish millisecond before. So it definitely increased more than 15% the QRS duration. Now what to do with this patient, okay? So, sorry, excuse me. So any thoughts about that? But, we talk with the EP definitely. So I'm just giving you some feedback from our colleagues. So we didn't, still he doesn't want to go for ablation, but flecainide actually improving his symptoms, but his definitely QRS duration is a problem. So he did improve with his symptoms. That's a bottom line, okay? So he decided that let's cut back the flecainide. Yes.
I interrupt for a second.
Yes.
Why did the EP doctor recommend an ablation? Based on what science?
No, they're thinking about his LVOT-VT and his symptomatic and his LV dysfunction there. That's why he reported.
And And my question is it just for symptom relief, or what are they trying to accomplish?
Two purposes. They're thinking about it's most likely coming from the phase 4. Okay.
Okay.
And they are thinking about whether patients symptomatic, whether they improve the symptoms and see whether they improve the LV function.
Is there any data on that somebody with ejection fraction of 40%?
No, we don't have.
It is just, so it is a gut feeling of the EP doctor, not based on science.
And
that is correct.
This LVOT is not easy to
ablate.
Yeah, and
yes, that is correct.
Okay,
and then
let me.
They are thinking about the trigger. You mean phase 3 trigger activity?
Phase 4. Phase 4. Phase 4 trigger activity. That's their thinking. Okay, I'm not expert on that, but that's why I need your minds. But there's a possibility of that because it's a trigger activity. And what they did, they cut down flecainide to lower the dose, 25 twice a day, and metoprolol they also cut down 12.5. And we repeated the ECG, and QRS duration came down. And interestingly enough, he feels better. He does exercise, and he much feels better. He's probably having some PVC, but he doesn't feel it. He said he feels much better. And we repeated another holter in 2 weeks. And there's not much non-sustained VT, and PVC burden was 6.8% before, it's about 1% right now. So we waited, we continued to treat that. I'm just letting you know what's the outcome of this patient. We repeated the echocardiogram. His ejection fraction improved actually 55-60%. So Dr. Rafique sir, how would you explain that?
No, but Aziz bhai, conceptually, if it is phase 4, that is like a SA node, AV node, spontaneous depolarization. That is the phase 4 spontaneous, then you are invoking automaticity. But if they are saying, your EP doc, if they are saying triggered, then it is either early after depolarization or delayed after depolarization.
We're talking about delayed after depolarization, DAD.
Yeah, that is phase 3, not phase 4.
No, DAD can happen in phase 4, DAD. Yeah, phase 2-3 is early EAD, phase 4 is DAD. That's my understanding. Yes. I think you might tell us a little bit more, but that's my understanding of that.
Okay, Aziz, after ablation, EF is how much?
No, not
sir,
ablation.
It is not ablation, sir.
He did not go for ablation.
Medicine, what is the EF now?
EF improved 55-60%. This is my patient, so I know him very well. Yeah.
All right. So the problem is this. Before it was 45 to 50%. Now it is 50 to 55%. It is
55-60.
But is it by echo or MRI?
No, echo. We didn't do MRI. Yeah, echo. Yes, I'm just telling you.
A test which has 5% variation. I mean,
no, I agree with that.
Yeah, if he had EF of let's 35, he went to 50, I would have said, yes, there is improvement. The bottom line is that I think we are getting into the domain which we have done in the 80s, that we were treating PVC, which is a surrogate marker, without proof until the CAST study showed that we are harming patients.
And I'm going to come to that. Okay.
Yes, it's an evolving field. This field has to evolve more before we can prove something. Few things. One, what percentage PVC is dangerous? Is there any big study to show that PVC decreases EF? That's one study. Second study would be that to show that, yes, if we got rid of the PVC, that EF improves in a mass study, not as an anecdotal case. Unfortunately, even in the United States, EP doctors are doing right and left ablation, and they are creating indications which are not based on science. That's my problem now.
Now, one thing that we saw, one thing though, that he improved his symptoms. That's the, I'm still thinking about, I'm not sure the psychological, but he definitely doesn't feel the PVCs. And we documented that PVC is now less than 1% over 24 hours. So that's a symptomatic improvement. I don't, that's definitely.
But the question is, we are using a drug in cardiomyopathy, which has been shown to increase mortality.
Okay, yeah, I'm going to come to that. I have a study from Emory. I'm going to come to that.
Sir,
recently published.
Sir, Adit sir, I want to interject for one thing. You
Sure.
said that this patient had ejection fraction of 40 to 45% with coronary artery disease, 20 to 30% minimal coronary artery disease. So
no, 45 to 50%, yeah.
45 to 50%, that is also a bit in the lower.
Yeah, a little bit down.
A little bit down with a very minor coronary artery blockage. So my question to you, guideline wise, can you use flecainide in this case?
Yes, actually, yeah, I have a very nice point on that. I'm going to come to that. Okay, let's go to that case. Okay, I'm going to.
এখানে আমি একটু একটা কোশ্চেন করতে পারি?
Yes, please.
যখন আমরা ফ্লিকাইনেটের কন্ট্রাইন্ডিকেশনের কথা বলি, পার্টিকুলারলি যখন এলপি ডিসফাংশন থাকে, তো এখন এটার অরিজিনটা ইসকেমিক অর নন ইসকেমিক, সেটার কি তার আউটকামের উপর কোনো এফেক্ট আছে মর্টালিটি? ইসকেমিকে ডেফিনেটলি এটা ইয়ে বাড়ায়, মর্টালিটি বাড়ায়। হোয়াট অ্যাবাউট দ্য fate in case of non-ischemic dilated cardiomyopathy who have PVCs, and if you use flecainide, what will happen to them?
Yes, let me tell you, there's a big study came out. We know that the CAS trial, when it came in, and first I believe I was in residency and Dr. Rafique Ahmed was my attending that time. And it's 1989, I believe, then refined weight came out in 1991. That definitely caused a huge problem because we used to treat PVCs that time with 1C. And we saw that patients who have coronary artery disease, LV dysfunction, and those, if you use this class 1C drug, then people have more mortality. And that's why it was terminated early. And from then, long time, we didn't use it. And actually still in the guidelines, in 2014 guidelines, that if the patient has a structural heart disease, which include coronary artery disease, they didn't mention how much coronary artery disease, and LV dysfunction, is presumably it's less than 40%. At that time is considered true LV dysfunction in that time in the guidelines, and they still do not think that we need to use it. Okay, but 3 years ago there's a data came out. I have to look at that. I'll tell you who's the writer of that. But last year, actually this year, there's the article came out from Emory, and Dr. Kiani and Dr. Bhatia, they are both my fellows, and they did a huge data from the Emory from that time, from 90s to now on, and they analyzed people who got the flecainide in different variety of degrees of coronary artery disease. Okay, so they sorted out one group. They analyzed at least more than 3,500 patients, and interestingly enough, the data shows that people who have non-obstructive coronary artery disease, mild disease, they actually benefit more with the class 1C drug with mortality and symptom relief, mortality and stroke, mainly cardiovascular mortality, then compared with the medication class C drugs. So I like you to just read that. It's published in JACC in July of 2023. So very interesting data we got, and it's a retrospective study, but it's a big study, and they showed that people who have minimal, like non-obstructive coronary artery disease, not having any symptoms with that, like stable, mild non-obstructive coronary artery disease, তারা কিন্তু better feel করছে with flecainide with mortality benefit. Okay, so compared,
they said that, we discussed this in our group. I don't know, maybe the way we looked at the paper is that it brings up the thought that it is an option to use. It is a retrospective study, from last 10 years or something, but it did not show better survival, even in the non-CAD group. However, it did not see the same noise of increased mortality with significant coronary disease. So there is no superiority, but it raises the hope that maybe in those patients without significant CAD, like your patient, flecainide is an option. They may feel better, but there was no benefit in terms of mortality. if you look at the results in that group without CAD, we dissected this, and there was no increased survival benefit. But it is an option.
Yeah, but according to the data, this shows like, class 3 AAD, if you use in this patient, they have a little bit poor survival compared to class 1C.
Yeah, if there is CAD, that is a poorer survival. That actually supports CAS trial. These authors did a do you have the slide deck on this? You have the slide deck. You can. They actually showed that it goes in line with the cast that bad CAD and flecainide 1C is bad.
That is correct.
So
yes.
There is no disagreement. But then they said, if the CAD is not that bad, maybe it is an option, because they did not see the same mortality risk, but there was no superiority with flecainide. There was none. But I mean, that was our understanding.
I got the point. Yeah, that is true. If they have a significant CAD, then do not use the flecainide. Okay, class 1C. That's the bottom line. But if they have minor CAD, it's an option, and they have better event-free survival. Compared to event-free survival means they have less recurrence, they have less, heart failure.
There is no significant difference. It was similar whether
I think hazard ratio was 0.4. So
no. You show me the slide.
Yeah, I have to get the slide. Yeah. No, that's fine. Okay.
But I think their notion was this, and I support your EP doctor's pathophysiologic understanding and use. First, he excluded the CAD, significant CAD.
Yes.
So that is clear. And then he had this hypothesis in mind that this is frequent PVC. PVC burden is so much that it is leading to LV dysfunction. So his theory is that if we suppress this without any underlying structural heart problem, we may get the EF better, and it did. So this is an interesting situation. But I think these Emory authors did a commending job that isolate those without CAD, and they see that it is safe. It is safe to use it, but no benefit in terms of survival.
One benefit I can think of, just one benefit, that to commit those patients, if you decide to do antiarrhythmic drug therapy, so you have choice like class 1C or class C, okay? And class C, sotalol or amiodarone. The question right now in coronary artery disease, probably sotalol will be better, but without significant coronary artery disease, if it's a minor disease, I'm not sure how sotalol is more effective, but amiodarone definitely is more effective. But the commitment to amiodarone, you need to be very serious, because it's a long-term commitment, and they have more side effects, short-term and long-term, with pulmonary toxicity, with thyroid toxicity, liver issues. So we need to be very careful putting the patient on amiodarone, though so far amiodarone is the best drug to keep in rhythm. That is true. But at the same time, my idea is that don't try to commit to amiodarone unless you have to. Okay, but some patients need it. Definitely, we agree with that. So then you have some niche there where you can use flecainide on those patients if they don't have significant CAD. And that's the point we could make. Okay, all right.
Yeah, but I think another important, we need to tell this audience that suppressing PVCs or suppressing the non-sustained VT from the amiodarone trials, we had no benefit whatsoever, even with LV dysfunction or without LV dysfunction.
Absolutely correct.
Zero benefit. Short term, we do amiodarone for the AFib and keeping them in sinus rhythm, but long term, we try to avoid.
All right, I think we had a nice discussion. Let's change the gear. Very simple questions I'm going to do. Can anybody in the audience to look at the EKG and comment on that? Just anybody. It's not that difficult, but there's some point I'd like to make.
Look at the rhythm is to be in P1.
It's not that difficult, but just feel free, just be bold, okay?
You can easily raise your hands. Okay.
Uh-huh.
Abu Naim Mahmoud Hassan.
All right.
Kamrul bhai. Kamrul bhai, make Abu Naim Mahmoud Hassan audible.
Assalamu alaikum, sir.
Please, আপনি আপনার পরিচয়টা দেবেন প্লিজ।
আমি
কোথায়
ডক্টর
আছেন?
আবু নাইম, আমি মেডিকেল অফিসার হিসেবে আছি উপজেলা স্বাস্থ্য কমপ্লেক্স রানীশঙ্কর ঠাকুরগাঁও।
Very good.
Sir,
Okay.
This 12 lead surface ECG with proper standardization. Here heart rate is around 170 to 180 beats per minute. Rhythm is regular. There is no distinct P wave. QRS complex is narrow. It's about 100 milliseconds, and there is ST segment depression in lead 1, 2, 3, V2, V3, V4, V5, and V6 also. And there is a notching after the QRS complex in lead 2 and also in V1 after the QRS complex. And there is RSR pattern in V1. So the ECG diagnosis is regular narrow complex tachycardia, most probably so as supraventricular tachycardia with right bundle branch morphology.
Mm-hmm. All right, thank you. I'm coming there. Let's do the poll on that. Let's see what's the average audience. Let's do the poll.
Kamrul bhai, give the poll for 15 seconds.
All right, I'm very pleased that most people answered the correct answer. Okay, this definitely it's not sinus tachycardia. You don't see any clear-cut P wave. Rather, you see some retrograde P wave, and sometimes it's a mimic. You see that AVR is to elevation and everywhere is to depression. You can argue with this left main disease. The patient is not having any chest pain. Sometimes proximal LAD or left main disease can cause this type of STEMI mimic, we call it. It's not atrial tachycardia. You don't see any atrial wave there. So it has to be in between B and C, whether it's AV nodal reentry or AV reentry tachycardia or AVRT. Okay. Let's look at that. I'd like to use the laddergram here. If you look at that EKG, so এখানে দেখতে পাচ্ছেন যে আমরা retrograde P wave একটা দেখতে পাচ্ছি, কিন্তু এইখানে কিন্তু ওইটা দেখতে পাচ্ছি না. We do not see it. আবার এখানে একটা retrograde P wave দেখতে পাচ্ছি, এখানে দেখতে পাচ্ছি, এখানে দেখতে পাচ্ছি, এখানে দেখতে পাচ্ছি, এখানে নেই. হ্যাঁ, so you see most of the time, but I see that sometimes you do not see it. That's a very important clue. That's the one important message I like to put on the ECG. If you look at the laddergram, so you see that retrograde activation of the atrium, that the reentry mechanism is going through the slow pathway, going to the ventricle, then fast pathway coming back, then it's getting blocked. Okay. Again, slow pathway going down, going to the ventricle, fast pathway coming back and doing retrograde P wave here. The key is that, look at that, this is the blocked part. So it didn't block, like here in the example here, it blocked here, that particular beat. Okay, it didn't go and depolarize the atrium. So what does it tell you? It tells you that to sustain that reentry tachycardia, it doesn't need the atrium. It doesn't need the atrium. That's the important point. So it's located in the AV node, it's circulating in the AV node. So yeah, it's sometimes backfiring to the atrium, but it doesn't need it. Despite it blocked, that tachycardia continues. That alone tells you, if you see that, that alone tells you it is not AVNRT. Because AVNRT has to travel. If you look at that, normal, like normal going through the AV node and coming back to the accessory pathway, still it has to use the atrium as a circuit. So if you block here and the circuit terminates, then it could be AVNRT, okay? But here it blocked, sorry, AVRT. But if it blocked, but the tachycardia continues to do so, that is independent of the atrium. So that one clue will tell you it is definitely AVNRT, okay? All right, let's go further. So our goal, definitely how to terminate this tachycardia, because it's very common and we need to know what we're doing there, okay? So I'm talking very simple case, but we need to understand what's we're achieving, what we do with this current condition. So anything we need to do, we need to have something to increase the refractoriness on the AV node tissue, right? We need to slow down the AV node, okay, certain way, okay? So first thing, definitely you don't want to, there's a way to do it before you go to the medical, pharmacologic intervention, right? Or the most important commonly you're doing is vagal maneuvers, okay? So, you need to know how to do it though, in the vagal maneuvers, okay? What it does, it correctly refractoriness barrier দেয়. When you ask the patient, make sure the patient lies down and with closed mouth, try to take deep breath and hold, not only hold and put pressure, like as if you're in a bathroom and trying to have a potty, okay? So, and try to hold for a few seconds, okay? So that increases the interthoracic pressure for a brief period of time, and that definitely stimulates baroreceptor in the arch and carotid bodies. That what it does ultimately increase the vagal tone, and that slows down the AV node, okay? Increase the refractory period in the AV node. That can break the AVNRT. Definitely have other options, pharmacologic agent, and definitely the patient is symptomatic, you cannot control with anything. You can do synchronized cardioversion. And definitely the most definitive treatment is ablation, because these are all of the things that can be potentially cured with almost 99% success rate of curing the AVNRT or AVRT. All right, and the success rate is about 20 in different literatures, 20 to 55%. Definitely carotid sinus massage is less, success rate. But sometimes you can put cold water or ice immersion, that's also 17%. But definitely try to do Valsalva. Make sure patients lying down with that, not sitting down, Valsalva, lying down. That affects more vagal tone doing that. So now let's do a quick poll and we'll discuss that why, okay? How are you going to terminate this tachycardia if the Valsalva doesn't work? I have 100% would be answer.
Stop the poll now.
Okay, so I'm very pleased. So everybody knows what to do. So definitely one thing that you need to make sure that adenosine, you give push and always get a syringe ready to push backwards quickly, and you need to get the vein, not the peripheral vein as close to the heart. So definitely at least antecubital vein, okay? But sometimes we use stopcock, that immediately we give the adenosine and then quickly flash of saline, okay? Because it has to go, because half-life is only 10 seconds, okay? Less than 10 seconds. The reason why you chose adenosine, okay? Because rapid onset and as short half-life, and definitely it works on adenosine 1 receptor. What it does, it a cyclic AMP mediated action. It causes some sort of asystole for the timing with hyperpolarizing the cardiac cells with potassium influx, and also it inhibits the calcium load, and also inhibits the beta agonist receptors, and basically it metabolizes quickly. So that's why it's the best drug to use it. So before you go for like, diltiazem or metoprolol, you could still use that, but this is a very quick way to terminate this tachycardia. And also it's an important drug to slow down some sort of arrhythmia, as for example, the patient has a flutter, you're not able to distinguish that with a twist one flutter or a sinus tach. Okay, and so you give that adenosine, you can see it slows down, you can see the flutter wave very well. So it's a quick diagnostic tool in the emergency room when you treat these patients.
Azizbhai, this is an excellent case to bring about this mechanism of action and what drug mechanism of
choose
arrhythmia and what is the drug that is tissue specificity. Because same AVRT situation, if it is antidromic and our target is to work on the accessory pathway, that accessory pathway tissue is different than the AV nodal tissue.
That is correct.
And not only adenosine causes harm because it can block the AV node and enhance the conduction through the accessory pathway, it can aggravate the situation. And that is the main reason why we need to understand the re-entry phenomena and what tissue is involved. If the re-entry phenomena and the tissue involved for the antigrade conduction through the accessory pathway, then we need a drug that works on that tissue, which is definitely the class 1A. By the way, the adenosine is not in the Vaughan Williams classification. Neither is digox. But it is an interesting drug that came out long after Vaughan Williams.
A very nice comment. Thank you. Let's see. I might skip a couple of cases. Let's see. Let's do this one, okay?
Sir, sir,
yeah.
Can I interrupt?
Yes.
Sir, before we move on to next case, if we can... Before we move on to next case, it is 10:45. So it's a bit late. What I want to say is that can we have some discussion on this case, particularly AVNRT? If we use, as a trainee, if I say, or as a student, I say, if we use amiodarone in this case, what is the problem, sir? IV amiodarone, if we give in case of AVNRT, it will also terminate. What's harm in not giving amiodarone?
Yes, comparatively, definitely, if you don't know it's AVRT or AVNRT, sometimes, if it is narrow complex, if it is a narrow complex that you're not sure, then the question right now is adenosine to use or amiodarone to use. I think amiodarone definitely has all the properties, right? It has properties of all four groups, and it works on the AV node. It will terminate. The harm is that amiodarone is a huge drug, and unless you're absolutely sure that is AVRT, I'll probably not go for amiodarone in this particular case if it's a narrow complex tachycardia, because it will stay with you at least 90 or 3 months about whatever you give the amiodarone in the body of the patient. But technically, you could do it. It could probably terminate the tachycardia, but I'd probably look at the ECG, and particularly if you see this type of some blocked P waves, and you're pretty certain, and also you see that a retrograde P wave very close to the QRS, that most likely AVNRT.
তোমাকে একটা কথা বলি তুষার, ভালো কোশ্চেন। রফিক ভাই একটা কথা বলি, ইপি হলো একটা বন্দুক মারবে, একটা গুলি ছুড়বে, একটা গুলিতে টার্গেটে মারবে। তো অ্যামিওডারন আমাদের কাছে থাকে, তাহলে we don't need EP doctors because you don't need any EP concept, just sarra guli marar moto. So it may work, but that is not the right drug in this situation. But you're right. If we use amiodarone, please use IV amiodarone. If you're giving oral,
It's going to.
Yeah, it's not going to work. It's a long half-life drug. It takes time to achieve the concentration you need. But IV amiodarone, yeah.
I think we are more than 1 hour. We can discuss that. I have many cases, but I'll probably hold off right now.
I was talking with Tushar. We need to have more about this topic, more lecture. And I really enjoyed today's lecture. Azizul bhai, আমার কাছে মনে হচ্ছে আপনার অন্য কেসগুলো নিয়ে এরকম করে লাইভলি একটু ডিসকাশন হলে আমাদের জন্য খুব উপকার হতো।
Now, what I do, I have at least 10 cases right now ready today, but I knew that I could not do that. So I put like very important cases that very simple and we face every day.
আপনি আরেকদিন আরো দুটো বা তিনটা আলোচনা করুন।
Yeah, I'll fit in between.
একটা কেক দুইটা কেস ডিটেইল আলোচনা করলে মনে হয় ভালো হয়।
Yes, I agree with that. We'll do it. So I'll stop here today.
I also feel, sir, rather than discussing too many things, if we can discuss one thing in total with
yes, mechanism understanding
and with differences of opinion. Likewise, আপনি একটা ডিসিশন বলছেন, তারপরে হাফিজ হাসান স্যার তাকে নেগেট করে অন্য চেষ্টা করছেন যে অন্য একটা ইয়ে করার। So in that way we can understand better rather than to discuss too many things.
I agree with that.
Thank you, sir. Thank you for very, very nice and excellent discussion. I'd like to request Abdul Jamil sir to give his comment, and then we stop our discussion lecture session today. Abdul Jamil sir.
Thank you, Tushar. Thank you, Azizul, for nice deliberation. And we learned some new things in the drug management, which should be practiced by most of the cardiologists and physicians regarding management of arrhythmias, especially BPC is a common thing, and sometimes we feel puzzled due to the patient's symptom. And often it is difficult to correlate with the patient's symptom and the presence of BPC. So we have to know which BPC should be treated and which not be treated and leave as it is. And only few patients need radiofrequency ablation for terminating the BPCs, with the risk of another foci to develop newer BPC. So thank you again. Thank you very much.
Thank you, sir. And thank you, Dr. Adi sir, Dr. Abdul Jamil sir, our mentors, Professor Rafique Ahmed sir and Professor Chowdhury Hafiz Hassan sir, and all the participants, respected physicians. We'll meet again in the next month, because towards the end of this month there will be some programs outside Bangladesh where most of our participants will be there. So in the next month we'll again meet, and probably we'll talk again regarding this antiarrhythmics. So up to then, good night, and hopefully we'll meet again. And thank you,
Thank you
for your support.
Assalamu alaikum.
Thank you.